Our next speaker is Professor Stephanie Wilson from Calgary, Canada. She also does not need much introduction. She's a clinical professor of radiology and gastroenterology at the University of Calgary. She's one of the first in the world to perform CEUS in the liver in 1998, and currently the biggest user of CEUS in North America. She is a recipient of many, many great awards and is a current co-president of ICUS. Stephanie will be speaking on CEUS LI-RADS algorithm and explain to you how to apply CEUS LI-RADS. Stephanie?
Thank you, Yuko, for the kind introduction. So in my presentation today, I will deal with contrast-enhanced ultrasound of LI-RADS, the algorithm and its application. So when we begin to look at CEUS LI-RADS, there are a few essential requirements. So first of all, when we apply LI-RADS CEUS, we have to be dealing with a patient at risk for hepatocellular carcinoma. We have to start first with a grayscale ultrasound examination and then perform contrast-enhanced ultrasound for characterization of a nodule. To do this, we have to have knowledge of the CEUS LI-RADS algorithm, and we have to recognize that the algorithm addresses all of the nodules in an at-risk liver, as was beautifully presented already by Dr. Piscaglia. So here we can see the 2016 version of CEUS LI-RADS. And so if we consider the left-hand side of the screen, we can see that we're looking at observations in a high-risk patient on pre-contrast ultrasound. And so we begin in the upper left-hand corner, and we're proceeding down to the bottom right-hand corner, where we have a small single entry for LI-RADS 5, which is hepatocellular carcinoma. So what I would like to do first is let's consider how we methodically go through the algorithm when we're performing a scan. And so if we look only at this portion of the algorithm, we can see that at the top left, that the first two things we have to do is determine if we have an adequate assessment for categorization of a lesion. And we want to look if the patient has treated lesions. And so what happens here? So when we're looking at the scan, we have to assess its adequacy and quality. And if it's inadequate, either on the basis of technical failure or patient issues that don't allow us to provide a category, we have to classify this as a non-categorizable lesion, and this has to be communicated to our referring physicians, possibly with recommendation of an alternate option as per your own institution. Secondly, we have to be aware of previously treated observations, whether it be with radiofrequency ablation, microwave, or TACE, and we have to recognize that today their classification is not part of the current version of CEUS LI-RADS. So if we go further, and we've removed now these two items on the left-hand side, we now come to untreated observations, and we're looking for lesions that may be hepatocellular or otherwise, but lesions that we can remove consideration for LI-RADS 5. So let's consider first the benign and probably benign lesions. So LI-RADS 1 involves definitely benign lesions. So what are things that we are able to put into this confidently? Well, it includes hemangiomas, simple hepatic cysts, and focal fat or fat sparing. But all of these require classic enhancement on CEUS. So they have to have both baseline and CEUS observations in agreement. So the value of CEUS for LI-RADS 1 is that benign nodules are a regular occurrence in both a cirrhotic and the at-risk liver, and we include all types of hemangiomas, including those that are flash filling. So the dynamic real-time capability of CEUS is superior to all other modalities to show the rapidly changing enhancement patterns of particularly flash filling hemangiomas. So let's look at a patient, a 59-year-old woman with HBV, and on surveillance scan we see a hypoechoic nodule with an echogenic rim above our threshold size of 1 centimeter, so we do contrast-enhanced ultrasound. When we inject the contrast, the patient continues to breathe but without problem, and you can see that we're looking at a hypervascular lesion which fills from the periphery to the center with discontinuous peripheral puddles. And this allows us to extract from our movie images at these time intervals, and you can see that this lesion has classic arterial phase enhancement for hemangioma with peripheral nodules and centripetal progression. It's uniformly enhanced at 1 minute, shows sustained enhancement at 4 minutes. So this is a classic flash-filling hemangioma. This is an LR1 lesion, and for this lesion we have completed our investigation for this study. Let's look at another patient with a full-blown cirrhotic liver, and on a surveillance ultrasound he also has a hypoechoic mass in his liver. And so on the baseline scan this is totally indeterminate. However, when we look at these contiguous frames in the arterial phase, we can see again filling from the periphery to the center of the lesion with multiple peripheral discontinuous nodules. And when we look at this with a bubble tracking technique, we can easily show that the lesion fills from the periphery to the center, and we see again the classic enhancement pattern for a hemangioma. Again, an easily dismissed lesion. This is not for consideration for future problem. Another patient with ethanol cirrhosis, and on a surveillance scan we can see a fatty liver and a dominant echogenic mass-like region in the liver in segment 8 abutting the vascular structures adjacent. So is this in fact a concerning lesion, or is this focal fat? Well, we cannot determine on the baseline scan, and so we take this large mass lesion and we look at it with contrast enhanced ultrasound. We can see in the arterial phase that the liver enhances uniformly and that we cannot detect the fatty mass lesion in the liver, so there's no arterial phase hyperenhancement. And we do sweeps through the liver regularly from the end of the arterial phase to about 5 minutes, and we see no evidence of washout, and again the lesion is essentially isovascular with the background parenchyma. So this is also LR1 classic focal fat on baseline and CEUS. So now we've looked at LR1. So what is our next category? Well, this is a probably benign category, and it has very strict regulations. So is there a probably benign lesion? So the criteria for this is that it has to be a distinct nodule less than 10 millimeters in diameter. It has to be isoenhancing in all phases, and so this is what we would traditionally have called a regenerative nodule. So many of the patients who are sent to us from outside surveillance clinics will send patients with a liver that looks like this. So here we can see a liver that's filled with sub-centimeter hypoechoic nodules when we look at the liver with a high-frequency probe. So if the liver is uniformly looking like this, it is a more difficult liver for certain, but this would be one where our suspicion would be less because there's not a dominant nodule. In any case, what can we do to look at this patient? Well, when we inject the contrast, there were obviously nodules everywhere. We can see that with the arterial phase wash-in of the contrast, that the enhancement is very uniform, that there are no foci of arterial phase hypervascularity. And so this is against there being concerning lesions. And then again, we do portal venous phase sweeps regularly, but intermittently throughout the portal venous phase. And you can see that contrast-enhanced ultrasound in many situations actually makes a very nodular liver look very homogeneous in the portal venous phase, improving the confidence of the investigator and removing these nodules from consideration. So this would be an LR2 liver. So now we've dealt with all of this portion of our slide, and now we're looking for tumor in the vein. So when we do our grayscale evaluation, we're looking for evidence of a soft tissue tumor within the vein. And so this includes both the portal venous and the hepatic venous assessment. And with these vein soft tissue densities, we may or we may not show evidence of a mass lesion within the liver parenchyma. So the contrast-enhanced ultrasound criteria for looking at soft tissue in the vein is that when we're looking for enhancement, that we must time the enhancement so that we are certain that any enhancement that we observe is in fact correlating with the arterial phase. And it must correspond on dual screen imaging with the mass that we've shown in the vein, and we have to look for washout in the portal venous and late phase as we do for HCC. So let's look at this beautiful case. This is a patient with HCV cirrhosis, and we can see a large lobulated echogenic fat-containing mass in the liver. And on the sagittal image on the right, we can see that the arrows are marking the ascending left portal vein, and we can see beautifully an echogenic soft tissue mass within the portal vein. When we inject the contrast in the sagittal plane, we can see that the mass lesion is enhancing and that the soft tissue tumor within the vein is also enhancing, correlating exactly with the grayscale image that is shown on the left for correlation. So here we can see a still frame at 15 seconds, and we can mark the thrombus within the vein on the grayscale image and show the exact correlate of the edge between the enhancing thrombus and the unenhanced portion of the lumen of the vein. When we look in the portal venous phase, the arrows are marking the vein again, and you can see that there is washout on the portal venous phase at 2.5 minutes, and this is a malignant portal vein thrombus. And so this is characterized as LR5V because we showed both the tumor in the vein and also the tumor in the liver. So now we're finished with that portion of the algorithm, and we move over to the very, very important category of LRM. And so LRM is a group of lesions that have malignant enhancement characteristics, and so that they're either definitely or probably malignant. However, they are not specific for hepatocellular carcinoma. So let's look and see what we have when we're looking at LRM, a very important category. So this lacks the specificity for hepatocellular carcinoma. And as Dr. Pascalia nicely described, these lesions can have variable arterial phase enhancement, but especially rim enhancement suggests LRM. And then in the portal venous phase, we're looking for two types of washout: early occurrence, less than 60 seconds, and with a marked or punched out appearance so that it's very black at the time of its first observation. Now, a very important issue for imagers is that any one of these observations alone qualifies the lesion to be LRM, and so this makes this very, very interesting and easy to observe. So let's look at a couple of patients. Here's a patient with a very fatty liver and a focal, well-visualized hypoechoic mass. This is an elderly woman with NAFLD. Now, when we look at this in the arterial phase, we can see that at 23 seconds, the grayscale image on the left shows our black lesion, and we can see on that image on the right a poorly enhancing liver, but with a rim enhancing lesion. And here we can see the value of the dual screen, where we can place the calibers on the lesion for precise localization of the enhancement that we view. And we can see the rim enhancement of this lesion. Now, as we watch further, we can see that by 37 seconds, that enhancing rim has completely washed out, and this is a punched out black looking mass in the liver. And so this mass, in fact, has got all of the criteria. It has rim enhancement in the arterial phase, it has early washout, and it has marked washout when the washout is first observed. So this would be categorized as LRM. These lesions we recommend almost always to have biopsy, and this is not suggestive of HCC, and biopsy confirms a cholangiocarcinoma. So let's look at another patient. This is another patient with HCV cirrhosis. Surveillance ultrasound shows a 2-centimeter hypoechoic mass within the liver. When we look at this nodule in the arterial phase, we can show that the mass in fact shows uniform diffuse arterial phase hyperenhancement. Now at 35 seconds again, we can see that this lesion shows washout. This washout is quite different than the last washout we looked at, and this is weak washout, but nonetheless it's early. So on CEUS evaluations, the importance of washout is unquestionable in the determination of malignancy, and both the timing and the appearance of washout, the intensity of the washout pattern, are critical. And so this patient goes on, and by 3.5 minutes, we can see that the washout has changed to a marked washout appearance. However, we use the initial washout of weak washout, as it's when we first observe it that we categorize the type. So we have arterial phase hyperenhancement here and early weak washout. So the early washout, as I've said, we only need one of our criteria. We classify this as LRM, as a lesion that's probably or definitely malignant, not specific for HCC, but we perform biopsy, and this confirms that this is, in fact, a well-differentiated hepatocellular carcinoma. And I show this case to make the important point that this LRM category is invaluable to make us suspicious of the possibility of the presence of a non-hepatocellular malignancy. However, some HCC will come into the LRM category as well, but will be managed well because we're recommending biopsy for the confirmation of their diagnosis. So now we've looked at the top half of our algorithm, and so this brings us to the very interesting aspect that's shown on the bottom half of the screen. So when we look at this, these are basically the nodules that Dr. Pascalia was describing in his very nice description about the hepatocarcinogenesis, the change of cirrhotic nodules through to first well and then poorly differentiated HCC. And so what are the things that we look at when we're looking at this spectrum of nodules? Well, there's basically 3 components to the evaluation. The first is how big is the nodule that we're looking at. The second is what happens in the arterial phase. Does the lesion have hyperenhancement, which makes us start to be suspicious of our LR5 lesion or our HCC? Or does the lesion in fact show hypo or iso enhancement in the arterial phase? Additionally, we look at the behavior over time, and what we're looking for is there washout? And so here we have on this y-axis, no washout of any type, and late and mild washout. And so of course we start out here with larger lesions and variations in both the arterial enhancement and the washout with our LR3, our indeterminate category, and then we move through our more suspicious category, LR4, and ultimately to our classic appearance of LR5 with the absolutely high specificity for HCC. So let's look at some of these categories. So an LR3 is an intermediate probability for HCC. It may be HCC or it may not. And so the management choices for looking at these lesions often include both biopsy and consideration of short interval surveillance. And so this includes a spectrum of nodules that vary, as we showed on our screen. They can have abnormalities or alterations of their arterial enhancement that aren't classic and their washout. So let's look at such an example. So here's a patient with ethanol cirrhosis with a 2-centimeter nodule detected on a surveillance ultrasound scan. So when we inject the contrast, we can see nice vascularity in the liver, and we can show totally homogeneous enhancement of the liver and no differentiation between the enhancement of the nodule with the adjacent parenchyma. So this is isovascular in the arterial phase. So if we look at where our nodule is, we can see that there is no variation in the enhancement. Now then we look again with our sweeps in the portal venous and late phase, and we can see that on these images as well, although there is some decline which is related to bubble destruction, that we do not have any variation. So this is an isovascular nodule measuring 2 centimeters, and so this nodule is an LR3 lesion. Now, what about more suspicious nodules? So LR4 nodules are nodules that have more features that are leading us to be suspicious of hepatocellular carcinoma. And this category particularly emphasizes the significance of arterial phase hyperenhancement alone on CEUS without anything else as being suspicious for HCC, in contrast to CT and MR scan, where washout is really essential for the diagnosis of HCC because of the frequency of shunting within the cirrhotic liver. So the criteria for LR4 include nodules with arterial phase hyperenhancement only that are greater than 10 millimeters, and also includes nodules with arterial phase hyperenhancement with late mild washout, but less than our size threshold of 1 centimeter. And it includes larger nodules greater than 20 millimeters with no arterial phase hyperenhancement, but with late mild washout. So let's look at an interesting case that we saw recently at the Foothills Hospital. So this was a patient who came following a surveillance clinic ultrasound of a severely cirrhotic small liver in a patient with HBV. So when we look carefully through the image file that's provided to us, we can see that there's definitely a hypoechoic nodule in a small cirrhotic liver, and it measures about 1.5 centimeters in diameter and is nicely marked on the bottom image. So this patient was booked for MR scan, which was reported as negative, showing no nodule and no arterial phase hyperenhancement. So therefore, following this surveillance ultrasound and that MR scan, the patient was booked for a CEUS in 3 months' time. So when the patient comes in 3 months' time, we can see the nodule quite easily. And we can see that the nodule is considerably bigger, now measuring over 2 centimeters in diameter. And so we perform, of course, contrast-enhanced ultrasound. So when we look at the arterial phase images, we can see that at 18 seconds, the liver is very poorly enhancing and the nodule is hypovascular. And this is persistent at 23 seconds, where we can see our hypovascular nodule. And then at 30 seconds, we can see that the nodule has become isovascular. We no longer detect the nodule. Looking at the 30-second image, including the dual screen and placement of the calipers for localization of the nodule, we can confirm that definitely this is isovascular at 30 seconds. Now, when we look at 1 minute and 2.5 minutes, what do we see? This lesion is washing out. So the first time we see the washout, we have weak washout at later than 1 minute. And then at greater than 2 minutes, when we watch at 4 and 5 minutes, we can see that the washout is striking. So this qualifies for LR4, a highly suspicious lesion for HCC. Further, the lesion is growing from 1.5 to 2.1 centimeters. So this is an ancillary feature on CEUS LI-RADS, and this favors malignancy. So definite interval growth favors malignancy. So of course this lesion is recommended for performance of radiofrequency ablation with biopsy, and this was biopsied and not confirmed to be HCC, but I will pursue this further because of our high level of concern. Now, another LR4 lesion, a 27-year-old male with cryptogenic cirrhosis, and on surveillance ultrasound we can nicely see 2 nodules, and when we do the arterial phase imaging with the dual screen, we can see that both of the nodules on the contrast image are hypervascular. When we look at them at 2.5 minutes, we can still see both of the nodules still hyperenhanced, and even when we go to 5 minutes, when the contrast has really left this cirrhotic liver, we can still see that they are slightly hypervascular as compared to the remainder of the liver. So a greater than 10 millimeter nodule with arterial phase hyperenhancement and no washout, this would qualify for LR4. Now, this patient has been under surveillance for a considerable time. The observations have stayed exactly the same. And so after 2 years of persistent size constancy with no growth, this lesion would then, this is another ancillary supportive feature suggesting benignity, this lesion would be reclassified as LR3. Just another LR4 where we can see a small nodule in the liver, a fatty liver, hypervascular in the arterial phase, and no washout to 5 minutes. A suspicious lesion requiring probably both biopsy and heavy surveillance. Now, the last lesion that we're coming to, of course, is LR5. So LR5 is the only category within the group that has only a single box. And so what does it have? It has a size greater than 10 millimeters. It has arterial phase hyperenhancement and it has late and mild washout. And if we have all three of those criteria, then we feel that this is LR5. So when we come to this distinction, whereas for the LRM, any one of our suspicious criteria were enough to make the lesion LRM, when it comes to LR5, we have to have everything, and then we have a virtually 100% accurate prediction that this will be hepatocellular carcinoma. So let's look at a classic example. A male with HBV, we can see a nice hypoechoic mass well visualized in the liver when we do our contrast-enhanced ultrasound. And notice again that breathing does not destroy the CEUS examination. And so this is obviously a well-seen, diffusely homogeneous and hypervascular mass in the arterial phase. When we look at this later, we can see our peak arterial image. At 1 minute, we can see that the lesion is still enhanced greater than the liver. At 2 minutes, it's isovascular to the liver. And at 3 minutes, it shows a washout pattern that is classic for HCC in that it is weak. There are still bubbles left within the washout region, and it is late at less than or at greater than 1 minute. So this and many other examples I could have shown you are all exactly the same because they all have all three characteristics regarding the size greater than 1 centimeter, arterial phase hyperenhancement, and late weak washout. So when you finish going through your whole graph, which we've now done, you have to reevaluate your category. And if it seems correct, that's fine. And if not, perhaps you should re-evaluate with careful review of the clips and the dual mode images with placement of calipers to ensure that where you're looking is in fact within the nodule when you're assessing hyperenhancement. And then we've already discussed to some extent the ancillary features of interval growth or interval size stability, and then tie-breaking rules to adjust the category. So when we consider applying the ancillary features, we're applying these to either upgrade or downgrade the category. And so we can only move by one category. And the important thing to recognize here is that although you can downgrade a LI-RADS 5 to a LI-RADS 4, we're not allowed to upgrade to LI-RADS 5 with ancillary features. We must have all three of the criteria that we've looked at. And so the ancillary features that we want to consider are interval growth. And then another thing that favors HCC, which we didn't have time to cover today, is the nodule in nodule architecture. And then at the end, we want to apply tie-breaking rules. And so if we're between two categories, what we want to do is always go to our area of comfort. And so if we look at the benign lesions here, and we have less certainty that they are definitely benign, we want to move to CEUS LI-RADS 3, which is our indeterminate category. And if we come up here to our more suspicious lesions, and we have less confidence that they're definitely malignant, again, we want to move the lesion back towards LR3, where we are more certain that we won't overdiagnose or miss a lesion. And so the algorithm, in summary, I believe really improves our performance as imagers for the evaluation of all of the nodules that can be seen in a cirrhotic liver, and it improves our communication as long as we educate all of our hepatologists and clinicians about the system that we're using. It allows for a confident and accurate diagnosis of hepatocellular carcinoma and provides for excellent management of nodules in a cirrhotic liver. Thank you very much for your attention.
Thank you very much, Stephanie. It was a wonderful, wonderful presentation. I think the LI-RADS category was very clear how to use it. Now, with the interest of time, I will limit the question to one. And there's a question about the injection of contrast dose. And I think these are also related to, technical trainings and how to be expertise. So one question was, does the injection dose of contrast depending on the severity of hepatocellular failure in a patient with cirrhosis? What is the minimum dose? I think Stephanie can answer, and then maybe mention about the training or the expertise on CEUS.
So when it comes to questions about contrast agents, we have to recognize that we don't all use the same contrast. And so I, in Canada, have used DEFINITY from Lantheus Medical Imaging since our introduction of CEUS in Canada now a long time ago. And so with DEFINITY, we do multiple small injections of contrast. Now, with SonoView, as it's marketed in Europe and in Canada, and Lumison now in the United States, the quantities are quite different. And perhaps Fabio might speak to that in just a moment, but I'll speak just to the other part of your question. So in terms of training, definitely you have to get started somewhere, but if you can go to a center where there is CEUS being performed, this is desirable, and there are excellent guidelines for training and for performance of ultrasound published particularly by EFSAM and WFM. And it does require, there's a quite steep learning curve. The studies are never easy, and when you're looking at cirrhotic livers, this in fact is one of the more difficult areas for CEUS. And so you have to, I think people that are dedicated to the performance of CEUS will do better than the casual performance.
Great. So I think with the interest of time, I would want to make a closing remarks. Oh, I think Dr. Piscaria would like to make a comment.
Yeah, just a very brief comment to the question before. In connection with the amount of sulfur hexafluoride to be injected is between 1 and 2.4 milliliters, depending on the sensitivity of the equipment and not on the degree of liver failure. The only situation when I would recommend the lower dose is when you have no portal inflow, like in portal thrombosis or reversal of portal flow or TIPS, because you have no portal flow in the parenchyma, you only have arterial perfusion. Then to separate neoangiogenesis from the background parenchyma, you have a shorter time, and I suggest to inject a lower dose. And I think regarding the expertise, it is not difficult to interpret the image. It's difficult to get good images. So first of all, you have to become very good in assessing cirrhotic livers. But once you are able to recognize a nodule, to keep the target in the right position when the patient is breathing, then interpreting the CEUS images becomes quite easy.
Great.